Welcome to Healthcare Quality and Risk Matters, the show where we dive into the topics that matter most in healthcare quality and risk management. Wondering about patient safety, quality improvement, or risk mitigation, but weren't sure who to ask or were afraid to ask? Well, you're in the right place. We create a safe and judgment-free space to explore these critical topics together that will leave you informed and inspired to make a positive impact on healthcare and patient outcomes. So let's learn and grow together because healthcare matters.
Well, good afternoon, everybody, and welcome to Healthcare Quality and Risk Matters. My name is Gary Bierc. I am the CEO of Aperitisoft Healthcare, and I am joined by my esteemed colleagues to, at least on my camera, to my left is Rob Santamoor, registered nurse and expert about everything healthcare quality and risk. And then to my right is Timothy L. Brown, the doctor of healthcare administration. Timothy is our expert on staff on anything.
Gary, I think we lost audio. There's in camera. There's
Am I back again on audio?
You are back.
There we are. Yeah.
But we want to.
And I think he's back out again.
No worries. As Gary's audio is coming back, there's into play. There's I'll continue the introduction and Dr. Brown. There's again just to continue with that everything. Hospital administration. There's ops development. There's a massive background in quality from a healthcare leadership standpoint. There's organizational awareness around quality is phenomenal. And Gary, there's our resident risk expert. He will claim to not be a healthcare risk expert, but we've been working together for years. There's his core foundational and advanced understandings of risk in general. And his ability to apply them to healthcare. Is wonderful. Today's topic is strategic planning. There's getting a seat at the table. And our format, is first discussing an incident of the month. We will talk about mainstream media, articles. There's general happenings in the healthcare world applicable to our topic. Then moving into Minute Matters, where we will talk back and forth, asking each other questions. To dig a little deeper into the topic. And we will open it up to everybody and invite everybody to ask questions throughout the entire podcast. If everybody that is currently listening, please feel free to drop in the comments where you are joining us from. And anything else you want to share about yourself. And throughout the entire podcast, please feel free to drop questions into the chat. We will make time to address them at the end. And as applicable, we will also bring them into the conversation. Well, Timothy, do you mind if I jump right into the incident of the month?
Absolutely. I think this is the perfect time to.
Awesome. So last month we talked a lot about the HRO process, and we talked about needing a system of high reliability. And the incident was the hospital in Ohio, the Hicksville Hospital, that ended up having to close. Because of massive amounts of fines. And the ability to sustain after those fines. Tanked them. Mm-hmm. The incident was so relevant and made so much sense that we really wanted to dig into it again for this particular podcast. And talk about why it would have been so important to have quality risk compliance. Helping with the strategic plan to keep the hospital afloat. So a little bit more background about the incident. Back in 2016, the hospital was found fraudulent. With an agreement that they had with the referring lab in order to pay back almost $25 million. To insurance companies for fraudulent claims. There's fast forward to 2021, as they're still reeling the issues associated with that. They try to implement new systems for. There's their EMR. And then they had a Medicaid payment system change. Then the pandemic hit. And then last year, the CEO gave them a 50-50 chance of surviving to this coming December. They unfortunately were not able to survive until this coming December, and now a community is left without healthcare. So Timothy, if you don't mind, I would love to throw you a question on that. What could have prevented it?
That's a great question. First of all, I'm really blown away to see that a community is now left without an overall healthcare organization to be able to provide for their needs. And if you think about that on the grander scale, that means if in an emergency situation, you have a hospital that's within maybe 20, 25 miles of you, likely they'll be able to provide whatever services you may need. This also would mean that we have extended wait times. We have extended times that we can actually get emergency services to maybe the rural areas around that overall local hospital that has now shut down. So thinking 20, 25-minute drive can now be exacerbated to maybe an hour and a half drive before that overall citizen that lives in that organization or lives within the vicinity of that overall healthcare organization. So to your question, Rob, what could have prevented this? I think the biggest thing that we always try to bring out in all of our conversations is the importance of having your quality leader or the voice of quality at the table for major decisions that happen within a healthcare organization. And that means your executive decisions that talk about budget. That means your financial decisions for growth. That also means identifying those risks and potential risks that may lead to a situation similar to the one that we see in Ohio. If you don't have your quality leader at that table, bringing in viable data that they can overall utilize to help make decisions, to help identify proactive ways of reducing risk, then I don't know what you're doing as a healthcare organization, honestly. And that doesn't necessarily mean that you can't have conversation outside, but when it comes down to decision making, that quality leader needs to be involved in every step of the process when it comes down to moving forward for your organization.
Great
question, Ron.
You guys can see and hear me now, right?
We can see and hear you.
Yeah, we can hear you.
I'm back. I'm back. Hey, Rob, I have a interesting perspective on this. I think you had mentioned that the hospital that was shut down, they were given notice that there were problems some 8 years before the shutdown. Is that correct?
So they identified the issue in 2015 and were found to be fraudulent in 2016. Yep.
I have a question to you two gentlemen. Okay. Obviously, healthcare quality or the risk department was not involved in the strategic discussions of how to turn things around. Why would a hospital not do that? Why would they not? And you guys take your turns on answering that question, but why wouldn't they include them? What possibly is blinding them to it? I guess that's the question I'm asking.
So if you don't mind, Timothy, I'd like to go first because this has been a high stress point in my career. I do frequently ask or advocate for a member of my team to have a seat at these tables. I am consistently turned away. Not consistently, that's not fair. I am often, more often than not, turned away from the table. And the request from me is usually for data. Please send me information, and they will then interpret how that relates to their financial bottom line.
Just so the audience knows, I don't turn you away from the table.
You don't.
You're talking about Clyde.
Not my current CEO. No, you advocate for us being at the table, which we appreciate, right? And they don't have anybody to put all of those linear lines together, right? How are we talking about the overlap? How are we closing gaps? And what impacts something else, right? There's so many elements to a strategic plan that require quality, risk, and compliance oversight. A strategic plan has to have a regulatory compliance section. And we often don't bring in the compliance people. we have to have the KPI section. How are we measuring our performance? And we don't bring the quality people in. And how are we assessing and preventing risk? And we don't bring the risk people in. And I don't understand. And so I don't have an answer for you, Gary. I just wanted to voice the fact that I do often get turned
Is
away.
there some kind of like hospital philosophical thing going on here, Timothy?
I do want to speak to that point because I want to go a little bit deeper on the side of psychology when it comes down to it. And I really believe this happens not only in healthcare, but many other organizations. There was a psychologist at Yale named Irvin Janis back in 1971 that coined the phrase groupthink. So if you think about this from a standpoint of your executive team, everyone thinks the same. Everyone kind of goes along with whatever the overall stance is. There's no one to actually stand out and say, hey, wait a minute, we should probably look at things from a different perspective, or maybe we need to be looking at the overall data. I think that's, and this is just my personal opinion, I can't speak for every organization, but I have seen this in many organizations where leaders are afraid to speak up or just don't speak up about some of the issues. So to the point of the overall organization in Ohio, you have a leadership team that was given information about their prior risk and understandings of things that needed to be changed in order for the organization to move forward, but it was not done. So obviously there was someone along the lines that was leading this group that said, maybe we should just keep the status quo and continue on and things will kind of fix itself. But you do need that person that's going to, as Rob said a few months back, be loud about quality, be open about what's going on, and just tell how we can move forward, identify those overall risks. Because if you don't have those forward thinking individuals, that diversity of thought when it comes down to making decisions, you can really shoot yourself in the foot and unfortunately damage a community, which I believe is what happened here in Ohio with the overall organization being shut down.
Well, why don't we move into the Minute Matters and our next sector. So if you're new with us, guys, we begin with the incident of the month, and then we get into a Q&A amongst the panel. We have only 1 minute to answer the question. That way we can keep me and Rob in check. Timothy's usually pretty good about it, but we can keep us in check. So, Rob, going back to the incident, the hospital had this warning, okay? Obviously, nothing happened to go along with it. Is it possible that they think that the results were an anomaly? I mean, what were the exact findings of the regulator that shut them down?
So what I was able to find on public record looks like it was a violation of the anti-kickback laws. Can you
elaborate a little bit more on that for our audience?
We had referring physicians that were referring to themselves or partners in the same line, same work, where there would be a conflict of interest. I will say, just in there's defense, and I don't want to imply any slander, that is actually really easy to do in a non-malicious way, which is why you need
inadvertently do it.
Yeah. Okay. Which is why you need quality, risk, and compliance to help manage those processes so that things are really intelligently documented. And smart controls in place to prevent fraud from happening by accident. Because fraud can't happen by accident. There has to be intent, right? But when you are negligent in forming process, you can have intent through a negligent process, right? Those gaps, there's that lack of education, that lack of control to identify those things happening before it got to a $25 million there's fine, is why quality, risk, and compliance are important to be at the table.
Yeah. And now, I mean, times are changing rapidly, and our healthcare system has to catch up. And if it isn't things like this, it's cyber risk, it's other things that are, we've had the healthcare system hacked on a major scale from ransomware. Hospitals individually are getting hacked. We've got to get to the point where the quality executives are considered part of the inner circle, and how you run a hospital. In my history, being a risk manager, it used to be this kind of thing. What's the insurance department have to do with strategic planning? Because there was a time when the risk guys were the insurance guys, and I'm sure it's the same way in hospitals, right? They're the guys that buy all the insurance and make sure that we don't have any claims. Basically, is the idea. Well, I mean, things have come a long way since then, and we need to think differently. Looks like we have Alicia has given us a comment here, guys.
We do, and actually, Alicia, if you don't mind, I'm going to play off of that and ask Timothy a question. Because I feel this to my core. One perspective I can share, quoting Alicia. One perspective I can share is in the fear of getting lost in the weeds versus perceived high-level thinking. Timothy, myself, Alicia, somebody comes to you as the CEO of the hospital, or any of your other executive team members, and I am describing, there's all of the connecting points, gaps, risks, and the whys. For example, there's coding for hospital-acquired conditions, very easy example, right? There's why I'm talking about how we're implementing our electronic medical record system. And how those directly tie to each other. And painting that path. It's a long path, but there's a root cause, right? It's in our drop downs and how we document hospital acquired conditions. It seems like I'm getting lost in the weeds when I'm talking to you about these things that we need to be aware of. How do we convince, from a quality risk perspective, that the weeds are sometimes important when we're planning these things?
First, I'm going to say it was the longest question ever, Rob, that I've ever received.
I think you used up this minute on the question.
I think what you just did really speaks to sometimes when we're speaking to our executive teams and we do get lost in those overall weeds of where does this web lead to? But I think the weeds are important to a certain extent. A lot of times when you're approaching your executive teams, they're not going to fully necessarily understand every intricate detail to where problems lie, but they do understand process improvement. They do understand identifying key areas and risks that we can eliminate to move things forward. So when I'm approaching an executive team, I always like to come with an executive summary. Tell me what the problem is. Tell me how we got there. Tell me how we're going to fix it. If you approach it with that type of mentality, then you allow the entire group to kind of move forward as well. Because you got, like you said, you're coming with the issues or risks that are going on within the organization. There may be 12 other people around the table that have individual risks and things of that nature that they need to focus on as well. So being very concise, very, very clear about the overall measurable objectives that you want to achieve, how you hope to move forward with that overall plan, having a clear cutout plan, I think really helps. Number one, get the buy-in, if you want to call it, from your executive team, but it also identifies a plan to move forward. That's the most important thing at the end of the day.
The healthcare industry may have to move, guys, in this direction that many industries have along the enterprise risk management concepts and theories, where they are establishing a role that pulls risk, quality, compliance, sometimes even audit, get all pulled under one chief officer called the chief risk officer. And the healthcare community probably needs to move in that direction, because now you're dealing with an individual that knows how to communicate at the C-suite level.
Absolutely. Well, can I ask?
Yeah, go ahead.
I was going to ask Rob a question, because he continued to mention risk, compliance, and also quality, kind of as almost like a trinity for organization. Yep. But they do play individual roles that require a different lens. Can you just kind of briefly highlight the lens of each of those key pieces to overall improvement of quality for your organization? Because you have the quality leader, the risk leader, and compliance. And in many organizations, they're one and the same. So what different lenses must they have?
Yes, every organization tends to do it a little different. There's whether it's by role or whether it's by overall like function, right? You're just assigning a function. But you're right, there are three different pieces. Compliance is really the blueprint. And all of the regulatory and legal aspects. What do we have to do? And what do we have to make sure that is happening, right? And then you have risk, which is proactive and reactive, hopefully way more proactive than reactive. But it is the identification, mitigation, and then the other elements, right? You're transferring, you're avoiding, all of those elements that go with risk. But it's the identification and it is the prevention. Of things that are happening that are non-compliant or not in line with your mission or vision. And then quality, is the improvement efforts, the measuring, the monitoring, and the maintaining, of internal performance and data. I could go on and on about the differences in all of those because they're very gray in some spaces, right? But they need each other to function. They need each other to function well. And all elements have to be incorporated.
Is it fair to say that all three elements are three legs of a risk management stool in a hospital?
Yeah, so I've seen some really good hospitals that are either saying this is all under quality or all under risk, right? But really, all of those are risk-based functions. I fully agree with that.
Yeah. So, this concept of a chief risk officer is probably something that needs to be explored more readily in today's environment to avoid things like being shut down in 8 years because you just can't herd the cats of the C-suite to get them focused on what needs to be done to not only function well, but to function within the bounds that the regulatory bodies are looking for. It's interesting.
I don't know everything that happened, of course, right? We only what we can get through snapshots of media. But knowing that they had the fraud claim and then they tried to implement new systems, what was the planning? What was the foresight? What was the risk assessment?
Right.
So did assess our current risk. We're paying $25 million. Was that all at once or was that over time? And is it time to implement a new electronic health system? Is it time to change payment platforms? Were those strategic in trying to increase efficiencies and be smart, or was it ill-timed?
We have talked about this before, guys, that a risk assessment, a forward-thinking risk assessment, trying to be predictive about things that can affect the hospital's performance and standing in the community, is something that must be done, but is rarely done by a hospital. When risk is discussed, it's discussed in terms of what incidents have we had and what audit findings have been presented against us, which is all reactive. It's all in the rearview mirror. And in the case of this hospital, they didn't react to the audit finding. I don't think they knew how. I think they really missed the understanding of what was the problem.
Gary, I agree.
Absolutely right.
I have partnered with a lot of hospitals that I do think it comes down to a lack of awareness sometimes.
It's just complete ignorance, and they end up shutting down. I mean, it's just amazing.
So
is there a problem with doctors where they just have blinders on with certain things?
Sometimes there's like, what's the PC answer to that? Sometimes we do get into a state that we know what to do because we know how the hospital's supposed to run. And we need to be open to all of the elements and all of the functions. And really bringing them in to assess. I had one really large hospital that I was working with, and they asked me to help them prep for their strategic plan. And they asked me for a SWOT analysis. And so I was like, sure. So I sent them over my SWOT analysis, and which was a stack of documents, a very significant analysis. And they were like, no, man, we're looking for a paragraph. And I was like, okay, so that's not a true analysis, right? How are we identifying our strengths and our weaknesses and know where to resource allocate and what hard decisions we need to make if we don't have data. No, I'm sorry, the Joint Commission said we have to have that in our strategic plan. There you go. So you're doing what you think you need to do, and you want to do the minimum.
That's a box checking exercise.
And we are not. Yeah.
That goes back to the comment that Alicia made about that fear of getting lost in the weeds. I mean, sometimes you just have to put your boots on and go in the weeds and get lost. And not necessarily lost, but get into the actual details of what's going on to identify what those key root issues are. I mean, if you can drill down to many issues, you really can assess and identify that they really are common things that need to be taken care of. Documentation control, identifying incidents, creating action plans to rectify some of these. And they're really simple. Or at the end of the day, maybe it could just be an assessment that needs to be done. But those core values of any organization can really help you get down to making the actual change that's needed. But if you're working towards improving that overall culture, it sometimes requires getting dirty, getting in those weeds, untangling the weeds, cutting some of the stuff down, and really at the end of the day, just getting down into what it is that needs to be done to make change happen. And I think that's where the hospital in Ohio went wrong. They got the information, but unfortunately, no one was willing to get into the weeds, get dirty, and find out where they can make the actual best change or plan forward.
Well,
As you can see, the hospital shut down because of that.
We can make the weeds make sense, right? So this should be an ongoing thing. So yes, we're supposed to have a seat at the table, and we can prove that we need a seat at the table through our daily operations. We should have a system of quality in the organization that aggregates all of our quality data, from our KPIs that are daily measured and pre-planned to our unplanned audit findings and incidents that occur. And then what is the feed? How do we get to the board? How do we get that information to the CEO? And that evaluation and transfer of information, right? That requires a system of quality. Mm-hmm. It requires an organized process. It requires an intelligent process. It requires daily buy-in. Of the weeds, so that you have a nice, pretty dashboard at the end of the year, right, to click on and say, all right, well, here's my strategic plan. I'm not going to look at my strategic. I'm not going to look at that data because it's too intense. Mm-hmm. It's creating that, as you've said in the past, Timothy, that culture around intelligent quality.
Yeah, that's good.
There is an adage, guys. We're talking about adage about the forest from the trees, getting into the weeds. But what about the devil's in the details?
Yeah, it is.
When you're dealing about things like this, I mean, I can imagine these doctors at this hospital were saying, look, my focus is on my patient, on giving quality care. You know, what does all this stuff got to do with me being able to do that job? Mm-hmm. And so I have a way of doing things. I'm giving good care. I'm continuing to do the way I do things. And meanwhile, Gary, they're violating any number of laws or even regulations regarding insider, whatever you were calling it before. and then they're in trouble, and they're in serious trouble. And when I was doing ERM work, I used to call it the arrogance factor. Sometimes risk is because people are just so full of the way they're doing stuff that they can't possibly open their minds to subtle changes sometimes that can make an enormous improvement to the overall organization. It's called arrogance risk.
You are not wrong. Yeah. Yep.
Or ego risk. We can call it ego risk as a category.
Mm-hmm. I like that. Ego risk. Yep.
Ego risk.
Hey, let's open up to the floor. Hey, guys out there, get us some questions. Throw us some ideas in the things you want us to respond to in your comments. So go in there and chat away and throw some questions at us as we're wrapping up our episode for this month. Does either one of you guys want to throw a last word?
I want to just kind of comment on what you just said about the doctors that focus on, well, I'm doing everything right. I'm in my wheelhouse, and not what does quality have to do with me? And I want you to take it from the perspective of the doctors that were working at the hospital in Ohio. Doesn't matter if you're doing everything that you need to do in your wheelhouse. If you don't understand that if you're looking at the big grand scheme of things, if the hospital shuts down, what does that mean for you? That means you have no patients. That means you're out of a job as well. Then whatever you thought you were doing in your overall wheelhouse is no longer a wheelhouse. So there is a bigger picture when it comes down to quality. And I think that each individual department, each leader should take that into consideration when we say, well, I'm just going to stick to my wheelhouse and only do what's right in my overall wheelhouse. You are connected to this bigger web. Think of it like a spider web. You hit one side of a spider web, the entire web's going to shake. And I think for this overall hospital in Ohio, the web just broke. And it affected all departments because the entire organization was shut down, unfortunately.
Totally agree.
So, Rob, what is next month's topic?
Yeah, so next month actually we'll play right off of this very cleanly. It's the cost of poor quality on October 30th.
I like it. Cost of poor quality. Folks, this is where you're going to start connecting all of this to the dollars and cents and the bottom line. And it's going to be an important show. So please mark your calendar for, what is the date? Do we have the date set?
October 30th.
October 30th. And we look forward to you all being there. Alicia, thank you for your perspectives and comments today. And for any of those out there that have not got their questions in yet, we couldn't get to fast enough, we apologize. We will be doing an after show right after this. You can find that on YouTube. And we hope that you'll look us up and seek us out. Any last things, guys, you want to say to the audience before we jump off?
No, please join us for the after show because I am itching to say a lot more.
Yeah, by the way, the after show, guys, we go ahead and we let it, we don't hold anything back. So we hopefully you'll enjoy.
Absolutely.
All right, well, we're signing off. Bye, everybody.